Okay, so what is the diagnosis? All right. That's my husband said cocaine is a hell of a drug. Okay, so Ted pretty much went over all of the sort of toxidrome pathologies that we see. So I just wanted to, with regard to cocaine, so I ran across some of the history of cocaine, which I found to be really interesting. And I have this map here, and it shows, this is actually from 2009, where coca leaves are being grown, primarily in South America, so Peru, Bolivia, and Colombia. And you can see carvings or like etchings in the caves dating back as far back as 5000 BC with these coca leaves. And lots of medical uses, ethnic and cultural uses with some of the Incans. And they would use it for like their spiritual ceremonies and then social events. But it really isn't the cocaine that we sort of know today in this country. The leaves actually contain about 0.5 to 1% cocaine content. And so what they do is they kind of cheat these leaves. And so they chew it, and it allows them, and it acts as a stimulant, almost as if they're using caffeine. And what they do is it supposedly allows them to work for longer periods of time with increased productivity at these high altitudes, which I thought was kind of interesting. All right. And then there are different routes of administration for cocaine. So anything that you can think of, pretty much all of the routes of medication, routes of administration that we use for medications applies to cocaine. So you can inhale or smoke it, which is the most common form here in the States. But you can also have PO form. So you can have a solid state, so chewing of leaves, or you can distill those leaves and you can make a tea or some sort of syrup or tincture. And then parenteral, where you would use it as an anesthetic. And then topical, where you actually grind the content of the coca leaves after you've extracted some of the more potent chemicals to apply topically for analgesic. So I ran across some of these historical indications of use for cocaine, which I thought were kind of interesting. This is a cartoon for using it as cure for dandruff. So that's a topical application. And then, I don't know if you can read this, but it says, tired, drink Coca-Cola. So Coca used to be in Coca-Cola, as most of you probably know. And so it says, if you're tired, just drink Coca-Cola and you'll kind of have a pick-me-up. Right? And then you can use it for toothaches, often used in dental surgeries, tonsillectomies, even eye surgeries. So I thought that's kind of interesting. And then also increases your GI motility. And so if you were constipated or you had an upset stomach, you could drink this and feel better. And then this is just a subcutaneous route. All right, so how is this relevant to us? Well, there are a ton of visits annually, right, in the United States emergency departments, 125 million to be exact. I think this was a 2012 figure. And 5 million are related to drugs and alcohol directly or indirectly. So you'll see your alcohol pancreatitis, cirrhosis, or you might see traumas related to drug and alcohol use. And then we see our chronic alcoholics, and they have misuse, abuse, dependence, and they might be going into withdrawal or opiate withdrawal. But a lot of these have to do with marijuana and cocaine, and those are the leading agents that we see. Okay. All right. So cocaine toxidrome. Ted went over most of this, but it stimulates the sympathomimetic system. So as we talked about earlier, alcohol and certain withdrawal syndromes of, how do you say, sorry, of stimulants basically can cause you to appear to be, like alcohol will have you show signs of withdrawal, okay, as if it were a cocaine toxidrome, because you're essentially opposite of activating the fight or flight. So with the sympathomimetic, we activate fight or flight, and you can see that anytime you're trying to escape a threat, your heart will beat faster, your cardiac output increases, your eyes dilate, your hairs literally will stand up on your skin. And you get this sort of piloerection. Okay? So signs and symptoms again. So you get altered mental status, you'll have increased CNS activity, sometimes so much so that you'll have seizures, and then this sort of mydriasis, diaphoresis, hypertension, hyperthermia. And I'll go over some more of the hypothermia and tachycardia and how that's important in the cases of cocaine toxidromes. Okay, so what was our case? So our gentleman actually confessed to ingesting 13 to 14 packets of cocaine prior to his arrival into the U.S. And he was concerned because he obviously had a seizure when he was out with his family, and he hadn't passed any of the packets yet. And he had no history of cocaine use previously, and therefore had literally no tolerance once these packets began to leak. Okay, so he had a seizure in the outline or outside before he arrived in CCT, and then during rounds in CCT, he had a second seizure, and Ativan was administered, and he didn't seize after that again. So what was his CCT course? So first, poison control was called, right? And so we stabilized him, so IV, O2, heart monitor, all that. And after poison control recommended whole bowel irrigation with Go Lightly, which is nothing light at all about it, and I'll go over whole bowel irrigation shortly. And then they also recommended Reglan and erythromycin because these are pro-motility agents. So you are trying to get this cocaine out of the system as fast as possible and also prevent him from vomiting. Okay? And then should he develop any QTC prolongation or widened QRS complex, you would want, because of the sodium channel blockade, you would want to administer sodium bicarbonate. This gentleman was just sort of borderline QTC prolongation, so sodium bicarb actually was not used because on the repeat EKG it was essentially completely normal. Okay. So GI was consulted, surgery was consulted, and then the MICU was consulted. All the meanwhile, the patient was sitting on the commode. All right. So, let me just talk about the consults. So GI was consulted for possible endoscopy because some capsules were still visualized in the stomach. But it's actually contraindicated to go in with endoscopy because there's risk of perforation with the instruments. Okay? And then surgery was consulted for a similar reason in case they could be retrieved because there was even one located as far down as the cecum. Surgery is really only indicated if they're having an acute, life-threatening toxidrome in that moment, meaning they have vital sign instability and they're crashing, and your only option is to get rid of the cocaine by extracting it and like full-on out irrigating the bowel in the OR. One thing about that too, GI and surgery, when a patient comes in, like Ted says, you can't believe anyone, so you really should be checking all of the orifices that there could be residue of cocaine, so the nares and then all of the vaults of the genital region, depending if you have male or female. So. Okay, and then MICU was consulted because this is someone who needs serial monitoring on a number of fronts. Okay, so admitted to the MICU, and they do all of these serial checks. One, so neuro checks for obvious reasons, but you have to do serial troponins and EKGs because cocaine can also induce ischemia. And they were actually collecting the bags in the NICU, so every time the patient would go to the bowel movement, take a bowel movement, I don't know who was digging out the packets, but they did, and the thought was until they at least got to 13, then they could stop. And then this Go Lightly regimen is crazy. It's 1.5 to 2 liters per hour. So when I was like going through the record and quadruped, it's like go lightly, potassium, potassium, go lightly, go lightly. And then Reglan and erythromycin. Okay. And
did you drink all this, or did you have to put an NG?
He actually had an NG tube in place, which I was kind of of wondering about because I was worried that the NG tube would potentially cause perforation, but I guess because it's to suction, that's not so much of a risk. But I would imagine these packets of plastic could be occluded during suction, so I'm not quite sure what kind of NG tube was in place, if it was just a simple one or like a sump. And then he was discharged shortly thereafter. So this person arrived on day 1 around 8 p.m. and then was discharged nearly 36 hours around lunchtime after the CT scan demonstrated that there were no more packets. One thing to note, if you remember when the initial abdominal exam was done, even though we suspected that maybe something else was going on, even though the patient denied drug use, you couldn't see the foreign bodies. So if you suspect any sort of drug packing, you really should do a CT scan because you can miss things on plain film. And I don't know the sensitivity of an ultrasound in being able to demonstrate that in the bowel, particularly if it's gone out of the stomach. And then he was discharged into police custody, actually on Augmentin, because when they did the repeat scan, it showed this consolidation in one of the bases of his lung. So they treated him for pneumonia. Yes?
Is it known how come police were involved? What?
I was wondering the same thing. I had a case of actually a body stuffer previously. He was like running from the police and ingested these bags of opiates and basically of heroin. And so it was like a really tense situation because the guy was like, no, I didn't swallow anything. I didn't swallow anything. And so I was like literally like whispering to this guy and like having him read my lips so that he wouldn't get in trouble with the police. So I'm not sure how the police became involved, really at all, because he came in on his own volition, and he's not from the States. So I'm not sure who would have called. All I know is the drugs were used, I guess, as evidence. So. But you know, I'm tough on crime, so. All right.
Yeah, right.
Some people want to build walls. So management and treatment strategies. This is just a little bit of a summary slide. So mostly supportive. So fluids, whole valve irrigation, and GI motility agents. Okay. Seizure management with benzos. And then temperature control. So Ted had touched on this briefly about rhabdo. Could this have been rhabdo? Well, he could have been developing a small component of rhabdo. He actually didn't have rhabdo. But patients who are seizing from cocaine use are at very high risk for developing rhabdomyolysis. So the recommendation is actually to chemically sedate these patients and, or chemically restrain them and not physically restrain them, because if they're seizing while they're in restraints or they're fighting you while they're in restraints, it's only going to increase their temperature and it's going to increase the muscle breakdown, increasing their risk of rhabdo. And if they're altered, there's really not much you can do for that. So you want to avoid restraints at all costs. And then it just kind of helps make them less agitated, therefore they won't have as much tachycardia. And then obviously rapport with the patients is critical, so they have to be able to share this information with you so you can make the diagnosis in time. And you really need to know if they're a body packer or if they're a body stuffer. Did they intentionally, like were they planning on carrying this, you know, from point A to point B, or were they kind of minding their own business, planning on using or planning on selling, and then they saw the police and they're like, oh crap, let me just swallow this real quick. Because the ones who just swallow super quickly and you know, maybe have like a single layer of wrapping are very high risk for bad outcomes, for life-threatening outcomes. Okay? And then you always want to get your consults on board, even though most times there really is no indication for endoscopy. Most times there is no indication for surgery. You want to have these consultants on board so that they're at least aware of the patient should something go badly with them during the course of their hospital stay. And then you have to continue to do serial assessments. And then, like I mentioned, the serial EKGs and serial imaging. references. And that's it. Any questions? Yes.
You talked about using sodium bicarbonate for the QTC prolongation.
Yeah.
I didn't hear anything about like
Calcium?
calcium. Thank you. No, not calcium. No. When we have, I can't think of it. Can I just press no? I'll get back.
Okay, I'm here.
It's really QRS prolongation. It's not, QT includes the QRS, so the QT gets longer when the QRS gets longer. So you treat QRS prolongation with sodium bicarbonate.
Okay, good. I meant to stabilize it.
It's your turn to talk, though.
Nope.